Welcome to the Massachusetts School of Law Educational Forum. Thank you for joining us. This program is brought to you by the Massachusetts School of Law as a public service and is shown nationwide. This is my father. He died of cancer. Words cannot describe his horrific battle with this deadly disease. Join me for the next hour as I talk with two experts in the field of oncology. We will discuss what cancer is, prevention, treatment, research, and clinical trials. Personally, nothing frightens me more than the thought of developing cancer. So, knowing all we can about cancer is crucial. Joining me first is Dr. Bruce A. Chabner, Professor of Medicine at Harvard Medical School and Chief of Oncology and Clinical Director of the Massachusetts General Hospital's Cancer Center. Dr. Chabner, thank you for joining me here today. Is a cancer diagnosis, doctor, the same death sentence that it used to be?
No, there's been a lot of progress in the last 35, 40 years. When I first entered this field, it was in the late 1960s. About a third of the patients with cancer survived for 5 years or more. Mm-hmm. That number is double now. It's 2/3. And many of those patients are cured. More than 50% are cured. So we have made a lot of progress. There's still a lot of room for improvement, particularly for the tumors that involve the more common tumors such as lung cancer and colon cancer.
What made you decide to pursue a career in oncology?
Oh, very complicated question. I had family experiences with cancer, and that certainly influenced my decision. Mm-hmm. I was very interested in the problem of finding drugs and new drugs for diseases, and cancer presented the biggest challenge. Thirdly, I just found the field very interesting from a scientific standpoint, and there was a great need for people in that field. When I got into this field, in the late 1960s, there were very few people from the medical side, the internal medicine side, that specialized in cancer. The field has grown tremendously since.
Which is good news.
It's good news, right.
How are new technological advances changing this very much feared disease?
Well, probably the biggest change has been contributed by a better knowledge of genetics. That is, what are the changes in DNA, the inherited material in each cell, which lead to cancer? And we know, we've learned a lot from studying families where cancer has been inherited. So now we know what the changes are in DNA, in the genes that control what cells look like and what people are like. Mm-hmm. To understand what causes cancer in these people. And this has provided important leads for prevention, for drug discovery, for assessing risk and identifying people who are at high risk. So it's really changed everything about the way we think about cancer.
How does a cell become cancerous?
Cells become cancerous by mutations or changes in their DNA. We're all born with a certain complement or set of genes which control all the proteins that we make in our cells, and that controls everything about us, from the way we talk and look to the way our livers and our hearts and all our internal organs function. And when mutations take place, either spontaneously or from exposure to X-ray or to environmental damage, or in some cases when these mutations are inherited from our parents, it increases our risk of cancer. And then we know that we do certain things that damage DNA. We smoke, we expose ourselves to sunlight, we expose ourselves to certain toxic chemicals, either drugs or pills that we take. Hormone replacement therapy is an example. It's a therapy which is given to women after menopause to prevent bone thinning, but also it has certain negative effects, and one of them is that it increases the risk of breast cancer.
Wow, I had never known that.
Yeah, so there are a lot of ways that we can increase or decrease the chances or risk of cancer, but ultimately all of them impact on the DNA which we find in our cells in our body, and that impact, that effect on DNA leads to cancer.
So the cause of cancer is a combination perhaps of internal as well as external factors.
That's right. It's things we inherit from our parents plus things we're exposed to in the environment, and the pills we take, the sunlight we sit in and or exercise in, and the radiation we're exposed to, and all sorts of things.
Contaminated waste sites?
Yes, probably. There is some evidence for that. It probably doesn't account for a large percentage of of cancer. Probably the biggest single factor is smoking. Smoking clearly increases the risk of cancer, lung cancer, cancers of the head and neck, even cancers of the digestive tract. And that's the biggest risk. But there are a number of other things as well.
And I do want to talk about some of the specific cancers in just a moment, but talking about family genetics, who is at risk specifically of acquiring cancer?
Well, the best understood risks for cancer are those associated with breast cancer, among the common solid tumors, the tumors that affect large numbers of people. In breast cancer, there are several genes now that have been identified that if they're damaged or mutated and then inherited, can vastly increase the risk of breast cancer. These are called BRCA1 and 2, breast cancer associated genes, BRCA. And then there are several other smaller players in this field that have been identified. Some of them at this hospital, actually. Mass General has been very important in this research. These genes are interesting. Some forms of mutation have been inherited from centuries ago. For example, among Jewish people from Eastern Europe, there are particular mutations involving BRCA1 and BRCA2, which are inherited and which lead to very high risk of breast cancer in certain families. The same thing is true of populations of patients with breast cancer from Iran or from Iceland or other countries. We know that the same genes can be affected in multiple ways and can cause breast cancer.
If we identify a woman that has a very high genetic risk for breast cancer, what are her options today?
There are several options. The basic one is increased surveillance for breast cancer at a young age. So mammography begins at a very young age for those people, should begin at age 35, and that contrasts with the average patient needing mammography at age 50 and beyond. Self-examination, regular visits to the doctor are important. Then there are the more serious interventions. Bilateral mastectomy in some families seems effective in preventing breast cancer where the risk is virtually 100%. There have been some nice studies published recently that show that you can prevent most but not all breast cancer in these families by just removing the breast tissue and replacing them with implants. But that's a pretty drastic step. There are also studies showing that certain pills that you take, particularly drugs which antagonize or inhibit or block the effect of estrogens, the main female hormone, these drugs can also significantly decrease the risk of breast cancer in high-risk individuals. So you have various options: surveillance, surgical option, and then pills to prevent it.
Do you believe that women are treated equally with respect to research and treatment with the cancers that are specific to women?
Years ago, there was some question about this. There was a great deal of advocacy for increasing the investment in breast cancer research. At the present time, breast cancer is the best funded of any form of cancer research. Prostate cancer, which affects men in about the same numbers, tends to affect an older population of men, falls somewhat behind breast cancer in funding. So the old criticism that the senators and congressmen, being men, like to fund the cancers that they got, research for the cancers they got, no longer applies. The actual leading cause of death due to cancer among women is lung cancer.
Is it really?
Yes.
Wow.
And it is not necessarily a disease that only occurs in smokers. Many younger women who have never smoked develop lung cancer, and it's a very serious, much more fatal disease actually than breast cancer. Survival from breast cancer is now 70 to 80% of patients. For lung cancer, it's only 10 to 15%.
So our audience certainly should really think before they light up another cigarette.
Yes, and that's, of course, smoking is important, and we need to stress that with our children and young people. But as I said, with lung cancer, there is a growing segment of the population who are getting lung cancer who never smoked. And we don't really understand the cause in that instance.
It might be environmental factors like the air.
Yes, or inherited factors. We really don't know. But it's a devastating illness.
Certainly some cancers could be prevented through healthier living.
Right.
Do you have any idea what that percent may be?
Well, we feel that smoking, as I said, is a major cause. It causes maybe 25 to 30% of all cancer. If we eliminated smoking, we could eliminate that group of patients most likely. Maybe not completely, but a lot of it. Preventive behavior certainly will help. The one thing I mentioned earlier is hormone replacement therapy, which should be used only in people who have a serious problem with bone density and need hormone replacement. There are alternatives now to hormones which are effective in preserving bone density and preventing bone loss with menopause. The other things we need to do are just early detection, and that involves mammography. It involves getting screened for prostate cancer, and that's a discussion that every man should have with his doctor, particularly by the time you're 50 years old. And colon cancer, which can be prevented now in many cases by just early detection of polyps. These are little growths in the wall of the bowel which can be detected by colonoscopy, looking up the bowel with a sort of telescope.
At what age do you recommend that?
The first colonoscopy, well, what we recommend is routine screening for blood in the stool with every physical examination, which can prevent or early detect maybe a third of the colon cancers. But beyond that, I think everybody should have colonoscopy at age 50, and then if they're negative, periodically afterward. The interval isn't quite clear from studies now. It probably should be 5 years. But if you have a colonoscopy and have polyps, these are early or precancerous lesions, you should have your repeat colonoscopy then more soon or sooner than 5 years, maybe 2 years.
Does the government do enough with their early detection programs for those people who are identified as risk but perhaps don't have the resources to pay for these type of screenings?
Very, very, very good question. We really don't have a well-organized approach to cancer detection, early detection. Maybe the best we do is in mammography. Beyond that, I don't think patients and the public in general is well informed about the need to do these other things, particularly to have this discussion about prostate cancer, the pros and cons of screening there, and certainly the screening for colon cancer is very important. There is no screening test now for lung cancer that's really effective. Other forms of cancer, they're not as well understood as breast cancer. We're unfortunately in this time where state governments and federal government budgets are under stress. Some of the programs that have been initiated for screening are at risk. One of those is the breast and cervical cancer screening program in Massachusetts. It's state funded and federally funded and partially supported by the hospitals, but the state funding portion of it is under review and could be cut because of the budget problems, and that would be a terrible shame.
Oh, that would be awful.
And you know, I'm very worried about this, and we're actively trying to be sure that this program doesn't get cut. But it would be very helpful if the citizens of Massachusetts could express their support for this.
And I'm sure other states at times face similar proposed cutbacks.
Not all states have these programs. Massachusetts is lucky to have it, and it reaches a population of patients who are underserved in general, and these programs are very important.
What scientific advancements are being made in the search to cure cancer?
Well, the major thing is that we're looking for new drugs, and all these leads that we're getting from the genetic research are the basis for most of the new drug discovery programs that are in place. The United States is fortunate to have the world's biggest and most advanced biotechnology industry, and a lot of that effort is being focused on cancer. Probably a half of it is devoted to cancer. And a lot of new treatments are coming into the clinic. We here at the Mass General, we're a part of the Dana-Farber Harvard Cancer Center, and we and our colleagues at the Farber, the Brigham, the BI, Deaconess are involved in many trials of new drugs. We have, I think at this point, something like 40 new treatments under consideration here in the very earliest stages of trials. And so it's a quite exciting time. I should add that with a few exceptions, nothing has dramatically changed the picture. It seems as though we make an advance one step at a time rather than globally. Yep. I don't expect that we're going to cure all of cancer with any single drug. We're beyond that point where we don't expect that to happen. But there have been some very significant advances in treatment in the last few years.
Doctor, what advice would you have for members of our audience who receive a diagnosis of cancer or a family member does?
It's a life-changing event, and I think you need to be confident that you get the best possible care. If you know, the first time around treatment is very important in terms of determining outcome. So obviously it's a disease that needs to be handled by specialists and by people that do this for their work all day. They don't do other things.
Yeah.
They just take care of cancer patients. And that applies to the surgery, the radiation therapy, and the medical oncology part of it. I think you need to go to a center where you're going to get care from all three specialists if you need it. I think you need to go to a center where you have access to all the specialties: surgery, radiation therapy, and medical oncology. You need to sense that you have a good relationship with the doctors, that you can talk to them about the details of your treatment. They give you answers about what side effects to expect, what the upside and downside of the various treatments might be. And then you need to think about it and talk to your family. This is usually something where the whole family is involved. You need the support of your family, children, parents, of course your spouse, and you need help during this time. And so often you need social work, even psychiatric counseling for some families to help you get through it. But you learn to do that, and you learn that there's life after a diagnosis of cancer, after you've finished with the treatment, and it takes time. I think the one thing that people have to realize is this is like any other major event in your life. It's not something you really get over. It's something you adjust to, and you learn to live with what's happened to you, and you learn to go forward with it, and you become a a wiser person from it.
I would imagine your mental state in remaining positive certainly must contribute to your ultimate success.
Well, I think it does, because it helps you tolerate the treatment and get over it, and listen carefully to your doctor. If you're emotionally distraught to the point where you're not hearing things and not understanding, it can be terribly difficult to undergo this kind of treatment. So you do have to be a pretty strong person, and it helps to have family members and friends involved who can steady you and make sure that you're doing the right thing.
My final question, if you receive a cancer diagnosis that is fatal, are there experimental therapies that one can gain access to?
Yeah, it's very important to know that there are lots of clinical trials going on with drugs which are not approved drugs by the Food and Drug Administration, but which have reason to be tried in people, and those drugs are available through cancer centers which have, like ours, major efforts in cancer research. And obviously I want to put a plug in for supporting cancer research, both that support coming from the government and from private organizations which support this effort. It's very important that we continue it. I know that times are tough now financially, but it's something that's among the highest priorities, I think, for our society.
I think you're right. I can't thank you enough for your time here today and for all the good work you do here at Mass General.
You're welcome.
Thank you.
They came from every corner of the country, from small towns and big cities. But they all shared one thing in common. They belonged to a family called Marines, a tough and determined few dedicated to protecting everything we hold sacred. And still, they come. Celebrate the 225-year history of those proud few who have earned the title Marine.
This is the story about a group of kids who volunteered.
Doing something nice for someone. We fixed stuff. Did some art projects with the kids. We fixed up his house. We worked in the woods. Cleaned up the park.
Did something for the planet.
We just did it.
No other reason. And you know what? It was great.
At first, they didn't know each other.
Well, that didn't last long.
This guy is really funny. Me? These are my new friends.
Are you into it?
Call 4-H or check out our website at areyouintoit.com.
Kids aren't afraid of other kids. Or people with different color skin. That's because kids know there are other things. Worse things. Bigger things to be afraid of. Like monsters from outer space! Remember, friends come in all colors.
Before you know it, she talks. Before you know it, she walks. Before you know it, she knows you. Before you know it, she has a heart. Before you know you're pregnant, when your baby's no bigger than a grain of rice. Before she's a twinkle in your eye, that's when you need to take folic acid every day. After that, it's too late to prevent some serious birth defects. Folic acid now, before you know it.
Welcome to the Simon Sinan Cancer Center.
You want to open your mouth, please? Oh, sorry. This has come down almost by half, huh? With a small amount of treatment. Yeah. Now, what I would recommend that we do is we go ahead and do the treatment today, and then I'm going to give you 2 weeks off, and you'll be able to rest up, and all the soreness in your mouth will resolve, and then we'll get you back. How does that sound?
Great.
Wonderful. This has been very sensitive to radiation, and it's shrunk down, as I say, about half. And what about pain medicine? Are you using the same amount of pain medicine?
I've been having pain. And like everything else, you know, Doc, After a while, it gets so sore that...
Right, but you're using less pain medicine now, is that correct? No, he's staying with the same amount. Okay. Well, this has been actually a very dramatic response to radiation treatment. So because you're in a hurry, I want to go out and let the folks know that he's going to get his treatment, and then he'll be off for 2 weeks. All right?
Okay. We'll be right back. So right now, Tim's going to program up the machine. We have cameras here, 3 cameras that we watch the patient, and we have sound also. These actually shape our field, as opposed to using what we used to use were big heavy blocks, but these are all internal in the head of the machine. This particular patient gets treated from 2 different angles. So now I'm going to go in and move things around. So the initial beam came at the patient from this way, and this beam's going to come from this way. The 2 will meet in the middle. So the dose is equally distributed in her.
This is where the CAT scan is. It's a very large room. It's noisy. They'll lay on this table. They would lay with their head this way. They would go through, get the CAT scan. It's very, very state-of-the-art here, and it's just excellent.
Joining me now is Dr. Samara Homsi, an assistant professor of medicine at the University of Massachusetts Medical School and the medical director at its Simon Synan Regional Cancer Center.
Dr. Homsi, are certain groups of people at risk to acquire cancer? Do they have a higher risk than the public at large?
Certainly. Unfortunately, everybody can develop cancer, you know, as a starting point, but the risk does vary considerably between people. You know, simple examples of this would be age. For instance, more than 75% of cases of cancer are diagnosed in people above the age of 55. The other major difference is in sex. For instance, you know, the probability of a man to develop cancer during his life is a little bit less than 1 in 2. The probability of a woman to develop cancer is a little bit more than 1 in 3.
Let me ask a similar question. What % of new cases of cancer are expected in this country this year?
I think the estimated numbers of new cases of cancer in the United States during the year of 2003 is a little bit more than 1.3 million cases. That's a lot.
Oh, that is a lot. What percentage of those people might be expected to survive cancer?
Roughly about 60% of people diagnosed with cancer would survive 5 years and beyond, and certainly a significant number of them, probably nowadays more than 30%, are definitely cured.
Oh, that is wonderful news. And I am assuming that has increased greatly in the past few years.
Sure. In general, the numbers have been increasing.
What are some of the most common cancers that we experience here in the United States?
Breast, lung, and colorectal cancers are by far the most common cancers that we see in the United States.
What is the most deadly forms of cancer?
Lung cancer is still the killer #1. And this year it's expected to kill more than 150,000 Americans by itself.
Are we making progress in the treatment and finding a cure for lung cancer?
Unfortunately, the progress in treatment of lung cancer has been difficult to come.
That is sad news. I understand that more women are expected to die of lung cancer than of breast cancer.
That's absolutely correct, Diane, and part of the reason for that is the increase in smoking in women.
You would think that with all the public awareness that people would decrease smoking activities. That doesn't seem to be the case.
I think overall the people are smoking less, but the problem, you know, as we would speak about, once you are exposed, you know, to a toxin, it takes, you know, even if you stop smoking, it takes several years, you know, for your risk to start drifting down. So basically what we see now is reflection.
Expertise, and that's cancer prevention. Can cancer be prevented, in your opinion?
To a degree. simple things, for instance, is, exposure to certain risk factors. If you stop smoking, your risk for lung cancer would be decreased significantly. So just by simple modification of your lifestyle, we know in these days that certain diets, diets which are low in fat, rich in fiber, can decrease your incidence of colon cancer. So certainly, again, like I just stated, by simple modification of your lifestyle, you can decrease, the possibility of getting cancer. In addition, we just enter the era of active prevention, chemoprevention. And there has been studies demonstrating that a medication called tamoxifen can, for instance, decrease the incidence of breast cancer. I just read, very elegant studies suggesting that aspirin may be a medication that could decrease the incidence of colorectal cancer. It's just a new era, but certainly we are making big strides in this area.
If we're looking at preventing cancer, I would imagine that early detection is crucial.
Correct. As a rule, in order to give treatments chance to be curative in cancer, you would like to diagnose cancer early and as early as possible. So certainly screening is a key here. For instance, breast cancer, and I think everybody nowadays is familiar with recommendations about screening for breast cancer. That's also true for other cancers, colorectal cancer, for instance, prostate cancer. These are the cancers typically where you can do screening and detect, tumor at a very early stage and give the patient chances of fighting it and defeating it. You can go a little bit beyond that and imagine certain scenarios where you have a person with a very strong family history of cancer. And certainly a lot could be done in this regard to put these patients under certain, strict surveillance, or even, do active interventions in order to decrease, the incidence of cancer. For instance, I'll give you simple examples which are very general, and after that I'll get a little bit to be more specific. You take a woman and you can basically use very simple informations and estimate the risk of a woman to develop cancer in 5 years or during her life. You can use her age, her ethnic background, her age at the first menstrual period, the age at which she became pregnant and had a full-term pregnancy, and her family history. And actually we have today programs, computer programs, where we can enter this information, and I think these are nowadays accessible to everybody, over the internet, where you can enter as a woman this information and get in return an estimation of what's the likelihood of you developing cancer, breast cancer, in the coming 5 years or during your lifetime. And based on this information, you can now talk to your doctor and discuss what's right for you, which could be more than the average.
Right.
Screening-wise, and even interventions with treatments. I just mentioned to you that tamoxifen has been shown in women with a certain risk factor to decrease the incidence of breast cancer. And actually, if we calculate that risk and we feel it's above the average and we have strict, cut-off points, to use, we could recommend using this medication, tamoxifen, as preventive measure, and has been demonstrated to decrease the incidence of breast cancer by about 38% in these women.
As I was preparing for the show and reading some of the latest studies on breast cancer research, it seemed to me that with a reasonable degree of certainty based on genetic risk factor, science can now tell, as you have indicated, what women have very high risks for developing breast cancer. And I was astounded as a woman to find out that one of the preventative treatments seemed so radical to me, that a woman could remove both of her breasts even before she gets the disease because of such a high risk factor. In your experience, does that happen often?
You're correct, Diane. We have this ability nowadays, and there are scenarios that I could explain to you where this is an option discussed with patients. For instance, over the last few years, a couple of genes have been identified. They are called BRCA1 and BRCA2. And basically, it was found that certain alterations, mutations in these genes, could simply mean a very high risk to develop breast cancer. And typically, these women would have a very strong family, not only cases of breast cancer in the family, but also breast cancer occurring at a young age.
Mm-hmm.
Actually, to be more correct, it's not only breast. The same people at risk for the same gene alterations to develop also ovarian cancers. So basically in our days, women with a very strong family history of breast cancer, and please understand, Dianne, that we have specific criteria to pick up these patients, we can counsel them and offer genetic testing. And actually, this is now commercially available. It's done by a simple blood draw. And we can do it. And once we have this information, if we do find that this patient is a carrier of this kind of gene mutations, we can certainly discuss a lot of things. And these vary depending on the cases. And it's all a process of counseling. And this can go from simple surveillance, where we are very strict, and we do a little bit more than we would do for the average, can go through hormonal manipulations, all the way to considering bilateral mastectomy. And actually, there have been studies done that showed that bilateral mastectomy in this group of women would decrease the incidence of breast cancer by about 90%.
Yes. Yeah.
And certainly, once we counsel the patient, a number of them would opt for this option, in particular being given the major advances in our days of reconstructive surgery and so on. I mentioned to you, for instance, that these same women are also at increased risk to develop ovarian cancer. And certainly once they are done, with having their family, certainly the option of bilateral oophorectomy or remove the ovaries could be considered. And actually it's interesting because this does not only decrease the incidence of ovarian cancer, but also does protect against breast cancer. So yes, all these options are there. And I think the key point here is that physicians and patients, need to be a little bit more aggressive, with the identification of this group of patients. Unfortunately, this is not an uncommon scenario. And once this is the case, these patients need to be counseled. And I think the word counseling is a key here. It's not, a simple visit, a simple blood test, a simple, let's do bilateral mastectomy. We take that very seriously. And it's a key to do all of that by medical professionals who are qualified, who would offer to patients counseling before, during, and after testing, because it's not just doing the testing, it's what do we do with the test results.
And I will say to you on air, if you will, what I've said to you personally is, I appreciate you took care of my dad through his cancer, and I appreciate that he was treated as though he were president of the country by you, and so for that I thank you.
I appreciate that, Dianne, and your dad was a wonderful person.
How have early detection programs changed the cancer mortality rate?
It did, not enough. Unfortunately, it's sad in our days that we still deal with patients presenting with advanced cancers. This is true for breast cancer, this is true for colorectal cancer. So there is still a lot to be done in this area. And basically, the reasons for that is education. And that's why I appreciate enormously what you do, Dianne, because I think cancer is a disease where knowledge is really power. And we still do see patients coming with colon cancer advanced. And when you ask why, oh, I didn't know that. I heard of mammograms, but I never heard of colonoscopies for screening cancer. Our recommendation now is every person, once that person reaches the age of 50, to undergo some sort of screening, which could vary from testing for blood and stool to sigmoidoscopy, or all the way to full colonoscopy. So there are screening guidelines, but everybody knows about mammograms. A lot of people still do not know about, these.
That's right, they don't.
Correct.
And my understanding is, as a part of the procedure now, testing for colon cancer, often they can simply remove polyps that would otherwise become cancerous, and it's a very routine thing these days.
You are absolutely correct. It's a procedure done as an outpatient under little sedation, and I would encourage every person reaching the age of 50 to undergo this kind of procedure. Sometimes it can mean simply the difference between life and death.
When you identify an individual or a family that has a high genetic risk factor for cancer, what do you do? Do you bring in the family and talk with them and counsel them about how often they should get screening tests?
Ideally, what should happen is that, this person is identified by the primary care physician, who would provide, basic information, explaining to patients why, or I should say to persons, they are not patients and hopefully they will never become, but explain to these persons that you need to go and see, a person who is a specialist in this and who has resources, to provide this kind of counseling and testing. And at this point, they are referred, to this kind of medical professional. And at this point, what happened is a detailed family history is taken. We have softwares to generate what we call pedigree, which is a detailed family history. Once we do that, we look at specific things, the number of cases, the age of incidence of these cases, and we use other means to calculate the possibility. For instance, if we are talking about breast cancer, and I won't say a lot about breast cancer because a lot of this also could be done for colorectal cancer. But for instance, to make it simple, you take a breast cancer and you calculate and say the risk of this person based on the family history to have this kind of gene mutations, gene alterations is about 10%. And most of us professionals taking care of this kind of persons would feel that once this possibility is 10% or above, these patients should undergo testing. So at this point, we'd bring that person, to the clinic and discuss with them again that we reviewed all of that and we think you are candidate to undergo testing. We explain to them how the testing is done. We explain to them the implication of that testing, not only on their health and on what they have to do with the test result if it comes back positive, but also implications from financial point of view, from psychological point of view. Imagine you test somebody and this person is positive, and then you tell them you have risk of developing breast cancer by the age of 80 of about 80%. That has serious psychological implications, and all of this should be taken into account. And that's why we say we don't want people to go and get a blood draw and then here are your results in the mail, deal with it. We'd like to do this in form of counseling by, again, trained medical professionals who would counsel the patients before, during, after. The test could be negative, could be positive. And there are cases where, unfortunately, we get results and we don't know what to do with because we don't have enough information about. And at this point, we would just recommend, follow up. But basically, the typical scenario, if the patient, the person is positive, what we would do, again, sit with them, counsel them, and go over the possibilities, what could be done about it to prevent cancer, or maybe to make sure if cancer does happen, it's detected at very early stage and curable stage. Now you ask me, what do we do? Patients and family, you need to understand that our obligation is toward the patient. And for obvious reasons, confidentiality, we cannot, take on our own. Let's call, the son and tell him, your father or mother carries this mutation. You are a 50% risk of carrying it. Please come and get, counseling. Our obligation is toward the patient, toward the person. We inform them of this. We encourage them that their first-degree relatives should be also screened because, like I just mentioned, the risk of a son or daughter of a woman, for instance, with this kind of mutation is 50% to have the same problem. And typically, these people would say, yes, I would like to talk to my family about and recommend that we be tested. But we do not have the right or the obligation to speak, to anybody else beside that person for obvious reasons, confidentiality.
Confidentiality. Doctor, I wonder if you'd tell the audience a little about some of the typical treatments that we use for cancer patients now, such as chemotherapy and radiation, and what's on the horizon.
Sure. Basically, we use three modalities, when we treat cancer. And actually, I should stop here and say, typically you need more than one modality, and that's why we always insist on the fact that treating cancer is a teamwork. It's a multidisciplinary area. It's certainly not the work of one person. And these modalities basically include surgery, where basically the tumor is removed, and then radiation therapy, where specific areas could be radiated to eliminate the cancer cells. And then the last modality is what we call the medical treatments, or in general terms, what we call anti-tumor chemotherapy. And certainly, in addition to that, you can add some hormonal manipulations and so on. These are the three basic modalities. It's very easy to understand from that surgery is basically local treatment. You are excising a tumor localized to a specific area. And basically, if the tumor is spread, a lot of times you cannot do surgery because basically there is limitation to what you can remove. Radiation therapy is similar in the sense that it is in general also a local treatment. You radiate a specific area, but you cannot radiate, the entire body at doses strong enough to eliminate, all cancer cells. So again, it's a local treatment. Anti-tumor chemotherapy, on the other hand, is typically in form of a pill or intravenously, and would go in the entire body and try to pick up these cancer cells wherever they are. So it's a little bit, in the sense, more general treatment. And that's why basically every treatment has its advantages, its deficiency, working on the cancer in different ways. And that's why typically in a lot of cancers, you would use more than one modality. The problem with a lot of these treatments, this is certainly true for radiation therapy, for anti-tumor chemotherapy, is that these treatments are not specific. For instance, they do kill certainly cancer cells, but they kill a lot of normal cells. For instance, anti-tumor chemotherapy has tendency to kill every rapidly growing, rapidly proliferating, renewing itself cell. Example of this would be the follicles of the hair, and that's why patients with anti-tumor chemotherapy would get very often hair loss. The lining of the mouth, the lining of the bowels, that's why they get mouth sores and diarrhea. The blood cells, that's why their blood counts would drop. So even if this treatment was effective, you are limited by the side effects, and you are limited by the total amount you can deliver, because there is limit to what a body can tolerate. So even if these treatments, are effective, there are limitations, and you pay a heavy price of side effects.
And you often have to go through them more than once?
Anti-tumor chemotherapy, typically you need more than one cycle. Actually, the way we do it, we give the treatment and then we give the body, time to recover from its side effects. So oftentimes it's sort of cycles, depending on the medication, every week, every 3 weeks, every 4 weeks, sometimes every 6 weeks. And typically you would need more than one cycle. What happened recently, and actually it's a very interesting area, is that we just started to learn how to be more specific. One example of this would be the so-called monoclonal antibodies. The immune system uses something called antibodies to fight many things. You get an infection, you get a virus, bacteria, your immune system will make antibodies which are going to recognize this virus or bacteria and kill it specifically. And we know now how to make monoclonal antibodies that would recognize specific parts of the cancer cells known as antigen and go attack the cancer cell this way. So you understand from this, Dianne, rapidly that the treatment is more specific. Actually, we went beyond that. We're able to sort of attach isotopes, radioactive molecules, to these monoclonal antibodies. And these monoclonal antibodies will go in the body, recognize this antigen, this part of the cancer cell on its surface typically, and deliver sort of radiation therapy to this cancer cell or to the surrounding cells. So again, what you are doing is being a little bit more specific in the treatments you are delivering. We made a lot of progress in the last few years identifying some critical elements for the survival of cancer cells, more so than normal cells. And these elements have been targeted recently by specific medications. And actually, we do have now in clinical practice FDA-approved medication that use these principles. And certainly, there is a lot to come and a lot of these medications at the late stages of development.
Anything out on the horizon that the FDA has not approved that you personally think has a likelihood of great success?
Sure. Medications in this area. There are a number of monoclonal antibodies, with or without isotopes, that I'm almost certain they are going to be approved. There are a number of medications that attack against certain parts of the cancer cells called receptors that are going to be approved very soon. And the results, like I just said, so far are very promising, and we expect them to come and be in practice very soon.
People that are diagnosed with cancer that appears to be fatal, they are not given a very good prognosis. Are there experimental drugs or therapies that they might be able to utilize in their hospital here in the United States? We often hear of people, especially with sick children, running to other countries because of the concern of the FDA approved.
Right. I think you are talking about, in general, the area of clinical trials. And certainly before a medication becomes FDA approved and becomes, part of the routine clinical practice, it goes through very, very long years of testing. We start simply in the laboratory in the cancer cells, and then we take it to animals, and then once we enter clinical trials in human beings, you still have several phases. Actually, we estimate that for every 1,000 molecule tried, there is one of them that would reach, the market and become an approved treatment. But certainly, many times, patients, even before this medication is FDA approved, can seek a clinical trial.
Here in this hospital, they could.
Actually, we do provide clinical trials. I think there is a difference between this and between, the medications, these strange things that we hear about, coming from overseas, left and right. And I think really every medication that has been studied enough from scientific point of view and has any chance to become one day on the market is available nowadays in the United States through clinical trials.
Do you believe, and I know I'm kind of putting you on the hot seat asking you this question, but might there be someday in my lifetime a cure for cancer or a vaccine to prevent cancer?
Sure. The problem of cancer, Dianne, is very complex disease. You want to compare it, for instance, to an infection. Years ago we had some serious infections, tuberculosis or syphilis, and basically, we know the reason. We found an agent specific to it, took care of it. Cancer is different. Cancer, like everybody knows, it's not a disease caused by one single thing. It's a multifactorial process where a lot of things, enter into play. And certainly, just from this point of view, it's very difficult, to say this is the cause, let's eliminate it. You need to start at lifestyle. You need to start at prevention, screening and prevention to make a diagnosis early. But certainly, even when you are beyond that, treatments are improving, and hopefully one day, we will get medications which are more effective currently on cancer. I always give, a patient this example. When I was medical school, when I was in training, I used to remember testicular cancer prognosis 0%. They all used to die. And, now it's a disease that we cure almost always. And simply because a medication called cisplatin came out and was very effective on cancer. So this can happen anytime. But I think if you want to say when are we going to find a treatment for cancer in general, I think it's a little bit not fair. It's sort of looking at one aspect of the problem. You need to start looking at the entire picture, as I stated, from education and lifestyle through screening, prevention, and then treatments.
What advice would you have for members in the audience that have recently had a diagnosis of cancer? Do you have any final pieces of advice for them?
The first one is be informed. Know exactly what you are dealing with. Know your disease, know your diagnosis, know your options. There are always options, and as a patient, you should be part of the decision-making process. You should not be told this is the treatment, this is what you should do. You should be involved. There are always alternative options that you should consider. Make sure you are comfortable with the surroundings, with the physicians and the medical professionals who are treating you. And then keep hope. A lot has been done in the area. We always speak about curing cancer, new treatments.
Doctor, tell us about this notion of cancer clusters and the validity of the studies in this field.
Sure. A cancer cluster is basically when you have more than anticipated number of cancers occurring in a geographic area, and you say you have a cancer cluster. If then you take a coin and you flip it 10 times and you get 10 tails and 0 heads, you look at me there and say, you're cheating. What did you do? It's true. But understand that if I flip this coin thousands of 10 times, ultimately at some point I'm going to get a 10 and 0. Okay? Cancer is a very common disease, and it happens very unfortunately that often that ultimately you are going to find in the same street 3 or 4 cases of breast cancer happening at the same time, simply because it's a common disease and it's a statistical coincidence.
Yeah.
That doesn't mean that investigation of these cancer clusters should not happen. Typically, again, these are occupational exposures. For example, you know, this is how we link the vinyl chloride, a substance, with certain form of cancer of the liver. But in general, if you are talking about cluster and neighborhood, the studies are extremely difficult to do, and usually they are not yielding.
Thank you for joining me here today.
Thank you, Dianne. Always a pleasure.
Every time an adult gives up on our kids, every time we surrender to the belief that their future is out of our hands, another child is left behind. I'm General Colin Powell, and I don't believe in giving up. That's why I'm asking you to join America's Promise. Log on to americaspromise.org or give us a call. Whoever you are, wherever you are, you can do something important. Pull your weight.
They won't leave you for someone younger. They won't notice you've gained weight. They won't fire you. They won't talk about you behind your back. All they'll ever do is love you. Find the love of your life. Visit PetFinder at aspca.org.
Hey, this phone's taken.
Son, will this help you?
Maybe the last thing you would do for somebody should be the first.
Thanks. Hey, I appreciate it.
A message from the Credit Union Foundation and your hometown credit union.
Morgan here. Oh, hi. Right now? Okay. The eensy-weensy spider climbed up the water spout. Down came the rain and washed the spider out. Out came the sun and dried up all the rain. And the eensy-weensy spider climbed up the spout again.
I love you, Daddy.
I love you, sweetheart.
Family. Isn't it about time?
What can I say? It's my girl.
From the Church of Jesus Christ of Latter-day Saints.
You know how inquisitive kids are. That's why you store sharp objects in a safe place. Keep medicines out of reach. And if you have a gun, you keep it unloaded and locked away. As concerned members of the television community, we urge you to be just as careful with television. Kids don't always know what they're watching. That's why you should.